Hi, everyone. Welcome. My name is Shabir Musa, Professor in Family Medicine. I'm coordinating the Executive Coordinator of AfroPHC, the African Forum for Primary Health Care. We're really glad to have today in this weekly CPD meeting, Dr. Shane Murphy, who's a registrar in family medicine. He's a bright young upcoming leader in family medicine, and we're really pleased that he's been able to share slides on easily interpreting ECGs in primary health care. Shane is basically a fourth-year medical registrar, family medicine registrar, but he's done a whole lot of other things, a diploma in HIV management, in emergency medicine, and even an MPH, and doing stuff around digital scholarship. So I think he's really a very talented young family physician. I think he's going to be qualified in literally a few months. So over to you, Shane. Thank you for being prepared to share these slides and your expertise on ECGs.
Perfect. Thanks for that, Prof.
You want to share your video maybe as people listen to you? I can hear you well and see the slides.
You can see the slides? All right. Sorry, let me just... Alrighty, hello everyone, welcome. Sorry for that. As Prof introduced me, my name is Shane, a registrar in family medicine. And today we just wanted to briefly run through electrocardiography or ECGs at the primary care level. As we all know, if we're honest with ourselves, that it is sort of an intimidating investigation that we're often not too familiar with, and the less we do of it, the more it sort of removes, or we remove from it, and we start to depend more on what the machine is telling us. So thank you for those that did fill out the MS forms, and there are some interesting answers, and we'll have a look at that towards the end. But largely what we would want to do now is just run through the basics of ECGs to refamiliarize ourselves with that. And then hopefully once we've done this session, as well as gone through the case studies and the answers, then we can look to, do more sessions and just practice our structured approach to an ECGs. Sorry, so I'm just going to stop my video. Okay, so in this session, we're just going to recap the basics of ECGs. We'll do some examples briefly, dependent on time, and then we'll see what you guys said to your test question and cases. I know Dr. Eels did have a good laugh at some of the questions and answers. So this is from Geeky Medics. Geeky Medics is a UK-based institution, and they do a lot of teaching targeted at undergrads and then sort of early postgraduate doctors or practitioners. And this is a very structured approach, and useful to us is that as we forget how to interpret different things, if we just can stick to a basic diagnostic algorithm rather than focusing on sort of different abnormalities or what we don't know or how to interpret, we can get through to a lot of the juice and make clear management decisions on the basis of sticking to that. So outlined here, we know first is to look at our heart rate, decide the rhythm. We're familiar with regular, irregular, or regular, irregular. Cardiac axis, then our waves, then our intervals, and looking at the different QRS complexes. And yes, it really is beautiful, and hopefully that would come through as we run through this. So an easy way to remember this is the rule of fours. So 3 different rules that have four components for us to consider. So often when looking at an ECG, it's an adjunct or a supplement to making a diagnosis and helping us determine what is the next steps of management for our patient. And so excuse me, so we must remember the history and what was the indication that we're doing this ECG. Was it a patient is complaining of palpitations? Did they have a history of pre-syncope or syncope, or are they unresponsive, or have they had a cranial crisis or the like. And so we incorporate that into our findings. Then we look at our rate, our rhythm, and our access. So those are 4 features. Then next we would look at our waves. And we know the first is the P wave, then our QRS, our T wave, and the U. We'll go through the U a bit later as well. And then our intervals. Intervals is often something that we don't really appreciate or look at and use it to interpret our ECGs, but they do add a lot of value to what we can gather from ECGs. And with regard, just back to the initial features and our history, and it's very critical that we know the indications to do ECGs. I think that in primary care, we often we find excuses, for lack of a less subtle way of saying it, to not do ECGs, either because we would have to do it ourselves, or the machine was dysfunctional last week, or we couldn't find leads, or we don't know how to interpret it. And it really is considered a standard of care. And so it's not defensible to not do an ECG when it is indicated. And strictly speaking, any person with chest pain should have an ECG done. For instance, a young male that's about 30 years old who comes in with precordial chest pain. And so something like the pink canary of CT syndrome or precordial catch syndrome are really diagnoses of exclusion. And so when I examine my patient and I feel at the sternocondyle junction that there is point tenderness there, that's by no means reliable that I don't need to do an ECG, or that this is not a cardiac chest pain. And I think often when we are rushed and stressed for pressure, we would see something like that and then say, okay, I've ruled out a cardiac cause. But it really is, an ECG is really a standard of care and something that we must build more into our practice and get more familiar with interpreting and using them. Okay, after that long story, moving on to the first steps of our interpretation. And so we said rate. And so determining our rate, there's several different ways that we can use. And most of us would be familiar with this method. So it would be using the space between our QRS complex or ventricular beats. So it's the distance between beats. And what you would do is you would find a QRS beat that largely falls onto one of the lines within the ECG. And then you would count the blocks between that and then divide 300 by the number of blocks to get our heart rate. If our beat is irregular, however, this is not a reliable means at all. And so we would look at the bottom of our ECG into our standard lead 2, and then we would count the amount of QRS complexes or ventricular beats in that segment. And then we know that is a 10-second strip. And so we would multiply that by 6 to get 60 seconds. And then that would also give us our rate. So this method that you can see on the slide is the easiest and quickest, but not applicable when there's an irregular or regularly irregular heartbeat. Okay, then rhythm. So rhythm is easy and something I think also as sort of junior clinicians, we just know when it's irregular, and we sort of are easily able to identify and diagnose atrial fibrillation. But sometimes you could have a young person or a fit, healthy person, and we know that you get a sinus arrhythmia. And so it would fluctuate with breathing. And the best way that we can do is what we call the line of, line of 4. And so we take a separate piece of paper, and then we just draw 4 lines on that paper at each of the QRS complexes, and then shift that paper along. And all of those complexes should fall still within that place. And so that's the easiest way for us to assess rhythm and to determine if it is regular. A reliable test that we can do that's a lot more accurate than eyeballing it. Okay, perhaps what we're less familiar is the regular irregular. And so here we can see this would be a paired beat. If you were to feel the pulse of the patient, we would say that it's irregular, but it is irregularly irregular. And so oftentimes we just think of regular versus regular, or sorry, irregularly irregular. And we don't really know that there's a wide different causes or differential diagnosis for everything that's in between. So regularly irregular. We do have additional examples of this, and there were some in the case studies as well. So, sorry, just back to the previous slide, we can see that these are ventricular escape beats, or not escape beats, ventricular ectopy. And so the first would be bigeminy, second trigeminy, and then the fourth quadrigeminy that causes an irregular beat. But for interest's sake, we can see that these are coming from different ventricular focuses. We know that they are ventricular in origin because they're very wide, but we know that they're from different focuses, one coming from the right ventricle, one coming from the left, because they're different in shape, and that has diagnostic implications later. And here is a atrial or supraventricular cause of a regularly irregular beat. And so this would be a second degree heart block. This is a Hay block or a Mobitz type 2. And every third beat is dropped. So we have our P wave or our SA node this firing. We have through our AV conduction, and then we have ventricular capture. And then again, and it's a fixed split. And then our third one is dropped. And then that happens regularly. And so this would result in a regular irregular block that clinically wouldn't be any different to, if we were to feel the pulse, it wouldn't be any different to our ventricular trigeminy. So cardiac axis, there's a lot of different ways to look at it and to consider it, but we know that the heart, we know that ECGs are leads or nodes that are put on the chest, and they just pick up the sum vector of the electrical activity that is moving towards that electrode. And so our heart primarily is sitting here within our chest, and the bulk of a normal heart is always aiming for an axis at a roughly 60 degrees. And so this is what we use in terms of looking at our limb leads to determine the axis. And so if we return, the easiest way that we can look at this is that we can see 1 and 2 should always be positive, as well as AVF. So when I look at my ECG, my 12 lead ECG, I will show you a picture of that later. So my left hand would be my lead 1 and my right hand would be AVF. And so if my axis is normal, it would be positive in both lead 1 and in AVF. And so the easiest way to determine if the axis is normal or not is I show a thumbs up with my left hand for lead 1, and then I show a thumbs up if the vector is positive in AVF with my right hand. And so I would have bilateral thumbs up. That's not a clinical term, but it's just the easiest way to interpret the axis. And so if I had a left axis deviation, meaning that my heart was shifted left, it would remain positive on my left hand, but my right hand would, most of the vectors would be facing away from that. And so my thumb would be moved down. And similarly, so yes, I'll show you that again when I start the video a bit later. Alrighty, so there's different ways to calculate specific numbers with regards to the axis, but for our purposes and all intents now, we'll use the thumb rule and stick with that at the moment. And the utility of knowing what a normal ECG looks like is that we do 1,000 of them and we determine what is normal. And so we know what is the normal rate, the rhythm, the axis, and we know what normal waves look like and what normal intervals look like. And then anything that is aberrant or deviates from that, then we can put in a differential diagnose and think perhaps this is a differential cause for that. And so The important thing when looking at ECGs is not to necessarily remember the entire list of different causes, but just to be able to identify the abnormality, and then we can go and search the differential for that. So we've done our rate, our rhythm, our axis, and now we would look at our waves and our intervals. And so when looking at an ECG in our specific leads, we would see our P wave. We know that it is followed by the PR segment. Then classically, dependent on the lead you're looking at, we have our QRS complex, our ST segment, and our T wave. And so this is what is defined as normal. And then we can usefully apply normal to all of our ECGs that we look at and see if there's anything different, what is different, and then that can help us to identify a potential cause for this. So useful in terms of here is our SA node, our AV node. These are little bundles that branch off to ensure atrial depolarization. And so this is the start from the SA node. This is the start of the SA nodal depolarization. And then as it moves, you have right atrial and then left atrial contraction that forms your P wave. And then it hits your AV node. And the AV node is sort of the gatekeeper that just filters it. And then if it says all is okay, then you have your interventricular depolarization as it moves down the interventricular septum, and then your right and slow it to your left side. So those would be both ventricles. Importantly, this is our ST segment, and ventricular repolarization starts at the end of the S wave. So it would start from this point here to the end of the T wave, not as opposed to just being the T wave in itself. And then again, we would start our cycle. And so that, yeah, that would be a normal cardiac cycle. And so I know that if my P wave is then buffered or if it's peaked, then I would know that there's something that is aberrant within my atria. If I know that I have a prolonged PR interval, then I would think that there's delayed conduction towards my AV node. If I have a deep Q wave, then I would think that there's perhaps a previous infarct that causes delayed depolarization of the interventricular septum, and then broadened as well would be damage to the fibers going to the left and right ventricles. Then repolarization, and why we always look at the ST and T and U segments when we are looking for dynamic changes or for acute coronary syndromes is because the heart is very sensitive to hypoxia or hypoperfusion. And so any irritation or failure of that will cause them to repolarize abnormally. And so any changes with regards to the myocyte or injury to the myocytes would cause the fluctuations with regards to that. So it's always helpful to understand the physiology when we're looking for pathology. So this is the beauty of the conducting system. And it's, as I said, just from the previous slide, nice to know how it would depolarize and how it would go. And then it really helps you to identify where is your pathology and what could be the likely pathology. So P waves, we mentioned rate, rhythm, axis, and then looking at our different waves. So P waves, we always want it to be a normal amount of P, and a P must precede every QRS complex. So this would be a healthy ECG where we can see it nicely. We did have the Mobitz too, where we saw that there was so-called excess P, where there was more P than there was QRS complexes. And in atrial fibrillation, we can see that there are no discernible P waves here. With regards to the P waves, I spoke to the conduction through the ventricles, and this is just an explanation of why we get P pulmonale or P mitrale, dependent on which atrium is affected. So in the healthy individual, a P wave is the sum of initial right atrial depolarization, and then shortly after, as the conducting fibers move to the left atrium, it would follow, and then we would get a normal P wave. However, if I have left atrial enlargement, then my conduction so if I have left atrial enlargement, my conduction would be slower into the left atrium, and then it the depolarization would take longer, and then I would get a bifid appearance. If there was right atrial enlargement, such as in pulmonary hypertension or tricuspid atresia or regurgitation, then the depolarization would occur slower through the right atrium, and then that is why I would get a P pulmonale. Okay, so these are then looking at our intervals. So we know that the PR interval is the distance from the start of the P wave to the start of the QRS complex. And we know that that should be less than 5 blocks, which is 200 milliseconds. And with regards to heart blocks, we always want there to be the same amount of P as there is to QRS complexes. And a fixed split with regular conduction is usually more common in our elderly individuals who just have degenerative changes. And so there's slower conduction from the P wave from the SA node to the AV node. And so that's a normal feature of age. Similarly, a second degree heart block, which is the Wenckebach, so we would know that as the type 1, Mobitz type 1 heart block, where there's a gradual widening of the PR segment, then we know that to be physiological. So it would be a small PR interval, and then as it increases, then finally the conduction would not conduct through to the AV node, and that's a physiological. But then in the Mobitz 2, where there's a sort of fixed splitting and then no conduction, that is considered a high-grade block, and then that person should be referred to cardiology. Okay, looking at our QRS complex. So we know this to be the TP segment. So this is the electrically neutral line that we use to assess our J point changes, as opposed to the PR segment. I'll elaborate on that a bit later. And so we have our P wave, we have our PR segment, and going into our QRS complex. Alrighty, so this is an ECG and it seems very abnormal, not really sure what to make of it. And so we still stick with our standard approach. So we know our rate, and so we're able to calculate our rate, our rhythm. This is a regular rhythm as well. And axis, this has now a sort of horizontal axis shift. So it's right axis deviation. And then looking at our PR interval, that is still regular. And then we have these deep pathological Q waves in our precordial right-sided leads. And then we have a somewhat biphasic T wave in V1, and then inverted T waves in V3. And so it's difficult to see this ECG, and not many people would be familiar with this, but we still do know what is normal. And so we're able to say this is aberrant, and the patient with this type of ECG does need repeat ECGs, serial ECGs, cardiac markers, and further workup. I'll touch on this ECG again later. And then just looking at different T waves. So we've done P wave, we've done PR, and then we've done QRS segment. And then we look at our T waves. We did also have this in our case study, and the T wave is really the most sensitive, earliest feature of any sort of changes or aberrancy in ECGs. So any sort of abnormal change with regards to that, sorry. This is me always getting excited with regards to talking too much and looking into too much physiology. But I think I just want to run through some examples of what's normal. I know, Prof, you said that we can't do live sessions, so I'll just chat to these ECGs. And so
you could, if you want, you could ask people to just pick up their hand if you want, and if they respond. Not sure that they will, but that's fine. Okay, if you want people, if people want to respond to a question you have, they can pick up their hand. You can give it a few seconds, see if it works.
So does anyone want to hazard a guess at this ECG? So this is the precordial leads, V1, 2, 3, 4, 5, and 6 of an individual. And here we can see that there is a P wave preceding every QRS complex. It does seem that that PR interval could be slightly widened. And we do have our RSR pattern. And then what we notice is that there seems to be a bit of ST segment depression in V1 and flipped T waves in V2 and V3. And so is there anything that you would like to know further on this case or about this patient? Or does anyone have an idea what these flipped waves could be?
Okay. Shiraz picks up his hand. Shiraz, go ahead.
Hi, Dr. Murphy.
Yes,
I guess some information that you might want to know as well on this ECG is with regards to the axis. So possibly, do they have a right axis deviation on the ECG? But most likely, these features are in keeping with the right bundle branch block. So the RSR pattern with a bit of QRS widening. The inverted T waves that are found in V1, 2, and 3 indicate that there's some sort of right-sided strain happening on that side of the heart as well.
Yes, Shiraz, thanks. So definitely, pulmonary disease pattern would be a foremost consideration. So in terms of your axis, right bundle branch block, strictly speaking, never causes a right axis deviation, but right ventricular strain, so in terms of acute PE or pulmonary hypertension, would cause, as we know, V4, V5, and 6 look more at the left ventricle. And then as Shiraz is pointing out, is that V1, V2, and V3 look more at your right ventricle. And so in the adult patient, this would be concerning for pulmonary strain. However, this is an 8-year-old male, and ECGs in children are always a different consideration. And so this is just persistent juvenile T waves in the pediatric patient, because we know that children, when they're born, they have equal right ventricular and left ventricular mass. And so their ECG shows more of an equivalent conducting pattern. But then as they grow up, we know that the right ventricle then sort of diminishes in relative size to the left ventricle. And so this strong right-sided pattern that we see here is just persistent juvenile T waves. So this is a normal ECG in a child. It was a bit of a tricky one, but yeah, Shiraz, definitely good insight with regards to the inverted T waves and the RSR pattern. Okay, this is, for the sake of time, Shiraz, this is exactly a similar case. This is a 37-year-old female on oral contraception, and she had a travel history. And here, this ECG, we can see very similar to the previous one, is that you have your delayed intraventricular conduction with your widespread, your right-sided strain pattern. And so looking very similar to the previous one, but if we take our rule of fours as we build our history into ECG interpretation, we can see that this is strongly suggestive of a PE. And also we have our S1, Q3, T3 pattern. So that's the S wave in lead 1, the Q wave in lead 3, and the T wave inversion in lead 3 as well. So that's quite specific for pulmonary embolism. A lot of people say that it's not very sensitive for pulmonary embolism, and yes, that is correct, but it is a bit more sensitive than what we have previously thought. Okay, and then this is a motor vehicle accident. So it's a patient who was riding a motorcycle, had an accident and has a reduced level of consciousness. Is there anyone from the audience that would like to hazard a guess at this ECG? Okay, so it can be, and the pitfall with ECGs is that we see that there's these obvious downward sloping or massively inverted T waves, and we can see that, and then we can sort of fall off the bus and be scared and not really know what we're saying, and that's why we tend to not want to do ECGs or not want to interpret them. But if I still follow my approach to ECGs, I can see that this is a regular rhythm. It has a normal axis and or even left axis deviation. So I would have my thumb up on my left-hand side in lead 1. I would have my thumb down in AVF. And so that is a left axis deviation pattern. But it does seem regular. My intervals do seem normal. Perhaps my QT is quite prolonged. QT, there are different formula dependent on the rate of the heart, but the easiest way to eyeball and see if your QT interval is prolonged or not is to look from the start of the Q to the end of the T wave. Sorry, I'm using the corner of the interface. So QT interval, and that should be less than half of the RR interval. And so I can see that this is bigger than half of the RR interval. And so this is a prolonged QT, but this is also quite a pathognomonic ECG, and it shows that these are cerebral T waves. So a very prominent feature in a traumatic head injury or even intracranial hemorrhage with elevated intracranial pressures. All right, so I'm going to move on to our cases. We do have other ECGs that we can put up onto Prof. Moose's website. And these were the cases that we found in the test. So thanks to everyone who did take the time to share that. This answer, I don't know if anyone is willing to share their guess. Actually, sorry, I'm just going to stop sharing quick and share the answers that people gave. Alrighty, is everyone able to see this screen?
Not quite. We only seen the sort of top of the form. Not even the, yeah, I think expanded or something.
Alrighty.
Try resharing it. Yep, better. You could share two screens at the same time, so you could get the answer and the ECG.
Okay. They do have a response section, so I'll just go to that. So review answers. Roland, you got this one right, but I'll look at the questions as opposed to looking at the specifics. And so the first one, I believe most people had this right. And so we can see that it's a regular rhythm. The rate is going, if we count the blocks, 1, 2, 3, 4. So it's going around 80 beats per minute. And then they're very difficult to discern any P waves. And there's the QRS widening and the massive upsloping T waves. And this is very classic of hyperkalemia. And so we do see that most people responded, noting that this was hyperkalemia. I know people call potassium the syphilis of ECGs because it can really present in any way or any fashion. So this question, we had the options of what we can see is we can see normal beats with a P, QRS interval, T wave, and then we have these regular wide bizarre complexes. So this would be premature ventricular complexes, and they are ectopic beats, but they occur in a rhythm. And if it's every second one, then it would be ventricular bigeminy, which most of us had. So ventricular ectopy is fine, but it's just yeah, nice to know that it's ventricular bigeminy, and it shows that whereas ventricular ectopy would be, it could be multiple different irritable focuses, this is a single irritable focus that is beating off regularly. And the question after this was, what would your disposition be of a patient with this? And so we know that all cells or all cardiomyocytes, they have the potential to conduct or produce an impulse. And the most common reason that the ventricular cells would have ectopy would be from hypoxia. And so classically, if this patient does present to us, we would want to check our electrolytes to see if there was any abnormal electrolyte that would want to do that, as well as our troponins to see if there was hypoxic injury to the heart that would be causing the irritable focus to have these regular escape beats. And so that was the answer to the next question. So dependent on your center where you work, you would want to do electrolytes and troponins to see if there was a underlying cause that was causing these escape beats. And then another acceptable answer would be to refer immediately. And this patient should be admitted to hospital. Reason being that if more than 1/3 of the complexes in your 10 centimeter or your 10-second strip are ectopic or ventricular in nature, then the diastole is insufficient for the myocardium to perfuse. And so they are likely to get cardiac injury. So ventricular ectopy, if you rule out the sinister and life-threatening causes, you could discharge them home. However, if more than 1/3 of the beats are, as in this case, are ventricular ectopy, then they are likely going to run into hypoxic injury of the heart. Okay, here again, 5 people were very honest. Thank you for that. And so in identifying our rhythm, we can see that there's normal sinus rhythm, normal P wave, QRS complex T wave, and that's great. And then all of a sudden we have these regular, broad, bizarre complexes. They are similar, so it means that they're coming from the same ectopic focus that's produced. So it's one focus that is irritable and sort of firing spontaneously, and then self-terminates, and then there's a pause, and then as the SA node resumes pacing, and then there's another repeat of that. And so these are runs of VT. So there would be sort of periodic runs of VT. And this is quite concerning. Usually if you have a acute coronary syndrome or a STEMI or myocardial infarction, when you reperfuse that part of the heart, then you do get these sort of, as it reperfuses, you do get this irritable myocardium that gives these runs of VT. So episodic VFib it would be a lot more awkward as if someone was scribbling over the screen. Sorry, so afterwards, I'm sure we're welcome to just discuss any of the ECG pictures if anyone has questions. So the rhythm here that we find, so we have our P wave, P wave, P wave, P wave. And so some people thought that this was a 3rd degree heart block. Sorry, a 3rd degree heart block, we would have complete atrioventricular dissociation. And so there would be no association between P waves and QRS complexes. Whereas in this case, we can see there's a P wave, then it slightly widens, slightly wider, and then the last one is drop. So this would be a Mobitz type 1 Wenckebach. And this is a physiological aberration. And so it would be safe to send this patient home and have a sort of non-urgent or elective cardiac OPD. If this was a Mobitz 2, and I think a lot of the audience would be arguing that this is a fixed distance between the QRS complex, is that that's a higher degree block, and it's likely that the patient could develop asymptomatic bradycardia, and so they would need more urgent cardiac referral for pacemaker. And the challenge, why it's quite nice that we have such a split response between a type 1 or type 2. And so when you have an ECG that you're not too sure, we mentioned the rule of 4s for checking our rhythm, but we can do that for our Ps as well. And so the P to P to P is going to be a shorter interval than our R to R to R. As sort of small and as subtle as that is a slightly widening gap. And by using the different, measuring out my P's and then using that to the RRR line to see if they are the same or they're different, determines my disposition for this patient. So as we said, if it was a Mobitz 2, this is a high-grade block that the patient is at risk to develop a symptomatic bradycardia with severely bad outcomes. But if it's a Mobitz 1, it's just a physiological block and not as sinister. Alrighty, so here we can see that we have a tachycardia. Our rate is going at about 150. It seems like it is a regular tachycardia. We have slight widespread ST segment, upsloping ST segment depression, but normal T waves. And we know that this is a narrow complex tachycardia. And so SVT is what we commonly refer to, but SVT is an umbrella term for both AVRT, AVNRT, sinus tachycardia, or sinonodal re-entry tachycardia. And so it's an umbrella term rather than a specific diagnosis. And the key difference here was whether this was going to be a sinus tachycardia or an AV nodal re-entry tachycardia or atrioventricular tachycardia. I do have a slide that I'll show you just now to help differentiate between an AVNRT and an AVRT. And so I see most people have gone for a sinus tachycardia, and it is very challenging to see that. And to advocate for sinus tachycardia, I would have to say that I see a P wave preceding every QRS complex, which is not the case in this ECG. There is a AV dissociation. And so very small mapped out, we can see that there's little P waves that occur at a regular rate. So if we were to map out the P's, they are completely dissociated from our QRS complex. And so that means that there's no communication between my atria and my ventricles, and that the tachycardia narrow complex is coming from below the atria at the level of the AV node. And so the correct answer for this one is an AVNRT. And the best technique that we would use to differentiate between this or to treat this, and as so both diagnostic and therapeutic, would be our Valsalva maneuver and the modified Valsalva maneuver as well. And then just that pressure on the AV node would cause a parasympathetic surge to terminate the rhythm. All right. Okay, I was hoping someone would go for that. Alrighty, so here we have a very bizarre rhythm and we don't know what it's going. We can assume that this patient is unstable because his heart is going, if we take 300, we divide it by 1, his heart is going at about 300 beats per minute, and every beat is conducted to the atria. And so I know that the AV node is the gatekeeper and the protector of the ventricles, and it would always, anything that's coming from a supraventricular area would be filtered through the AV node, and the AV node would not let it fire off at faster than 150 to 200 beats. And so if it's going at 300 and it is a narrow complex, I know that this rhythm is not going through the AV node, and there is likely an additional conduction pathway that is carrying impulses directly from the atria to the ventricles, such as our Wolff-Parkinson-White or Lown-Ganong-Levine syndrome. And so this is an atrioventricular tachycardia, 11 responses. Yes. Yeah, so VFib, definitely, I think, also when you approach your ECG, your rule of fours, you take your history, this patient would have palpitations and would still have some semblance of perfusion, whereas opposed to the VFib would be unconscious. VFib would also be slightly more disorganized, and over time, it would become, from less coarse, it would become more and more fine as the ATP depletes. So the correct answer here is AVRT. And a key thing in determining between AV-NRT and AVRT is that for the previous ECG, this was AV nodal re-entry tachycardia going at 150. So the AV node is protecting it. And then the agents that I give do work on the AV node. For instance, adenosine just blocks the AV node. And so it would stop all of these conductions. I would have a bit of period of asystole, and then I would have the sinonodal normal capture pathway. Whereas if I have an AVRT and I were to give this patient adenosine, block the AVRT, block the AV node, then it would, my atrial dysrhythmia going at 300 to 600 beats per minute would conduct on a 1-to-1 basis. And so if I thought that this was a supraventricular tachycardia because of the narrow complex, so here we can appreciate in AVL, we can appreciate that this is the T wave repolarization, and then this would be a narrow complex. So in SVT, I give adenosine, then I would take out whatever beneficial function my patient has from the AV nodal blockade, and I would cause this patient to go into VFib. Alrighty, some tough ECGs around here. So here we have really broad, bizarre beats and difficult to interpret. And for myself, if I'm sitting in the casualty and I do have someone bring an ECG to me like this, I would look at the top of my ECG machine and the interpretation that says ST T wave non-specific changes, MI likely, and then I would sign and then say I'm not sure and refer off to hospital. However, the correct answer, a technique when we have very bizarre beats, we know that these are ectopic, broad, bizarre, wide, and then we can see that there is capture again. So we have a P, QRS, we have there's our T wave, we have a P wave, QRS, and then it starts again, and we get these sort of runs of ventricular tachycardia. And the key when we see something as bizarre as this is to look where there is no noise. And so when I look at this ECG, I look at the normal waves. And so I can see my rate is going 1, 2, 3. So it's going just under 100 beats per minute. The rhythm at this stage is regular. And then I look at my waves, they look normal as well. Either this is a U wave or it's a first degree heart block. But of concern is that I have a prolonged QT. So my Q to my T is prolonged. So that would be suggestive of hypomagnesemia that's causing my ventricular tachycardia, and that could lead to torsades. But when I look at this lead in V2, I see that this is a coved ST segment with slight downward sloping. And so this is actually, this case was a 50-year-old female that had a upper respiratory tract infection, and then she has Brugada syndrome. And Brugada syndrome is a sodium channelopathy that can present in the precordial leads with a coved ST segment is one of the diagnostic criteria. There are other type of patterns, but the key take-home point would be when I have an abnormal ECG is to try and look at where things are silent, and I can make out what the normal ECG pattern is looking like. So the correct answer here, runs of VT, yes, that is correct, but the true underlying concern was the sodium channelopathy. And then if I'm at the primary care center, because I am concerned that my QT segment is prolonged, hypermagnesemia would also be an acceptable response that would beneficially, without having to do any blood gas or ISTAT or so, I could empirically treat this patient as well. Alrighty, drug overdose. Yeah, so I see it's irregular. I see that there's widening of my QRS, primarily the terminal QRS, my PR segment widening as well, and then sort of this slurred ST segment and sort of tombstone appearing T waves. I don't have any discernible P waves in my standard lead 2. And so the correct answer here is tricyclic antidepressants. So this is a tricyclic. We know tricyclics are very dirty drugs and they cause sodium, potassium, and calcium blockade. But a key giveaway would be the tachycardia. So where beta blockers would cause a bradycardia, calcium channel blockers also a bradycardia, and then we would have a very markedly prolonged ST segment. Digoxin as well. You would get a bradycardia with all of these. Classically, paracetamol, we don't get too many primary toxin-related dysrhythmias, and then no answer provided is just the confusion. So this is very difficult to note. We know that also for tricyclic antidepressant poisoning is that you do get this large R wave in AVR, and so I don't really have an idea of what's cracking with my ECG, so I follow my normal approach, and then I can see what's abnormal is that I have this widened QRS with AV dissociation, and I have these very sort of pronounced ST T wave segments, and I have an extreme axis deviation. And so I would then Google from a reputable source, and I would see a differential for what is ST, what causes extreme axis deviation and ST segment elevation in AVR. And at the top of my list, tricyclics would definitely come up. Right, next ECG. So this ECG, and I didn't give you history because really ECGs are beautiful and they can tell us so much more than what we interpret from them. And key to this ECG is that there is a pacemaker here. So there is a ventricular pacemaker. We see that the atria are, there's AV dissociation. So the atria is not a or atrial and ventricular pacemaker, but it just has the ventricular pacemaker firing with its capture. And we know that pacemakers would classically produce a left bundle branch picture. And so we can appreciate our William. And then, so the correct answer is that this is a left bundle branch pattern, although it's due to a pacemaker. And then the key was whether it was with a myocardial infarction or without a myocardial infarction. And we know that diagnostic criteria for myocardial infarction in the presence of a left bundle branch block, we used to say that a new or presumably new left bundle branch block is indicative of a myocardial infarction. However, that's an outdated way of thinking. And so there's the modified Scarboza or Smith's criteria that we apply to the bundle branch block to determine whether there's a MI in the presence of a bundle branch block. And so there are different criteria to please look up just in your own time. But here we can see that there is concurrent ST segment depression. So if I have, this is a, sorry, so my QRS complex is facing down and my ST segment depression is down as well. So that's concordant ST segment depression in my precordial leads. And so this is diagnostic for a heart attack in the presence of a left bundle branch block. Other criteria that they use is that we can see that this ST segment elevation is discordant, but it's not excessively discordant, meaning that it's not more than 25% of the depth of the preceding. So that would be a different criteria for excessive discordance or excessively discordant elevated ST segment. But in this ECG, we have concordant ST segment depression. So this is a left bundle branch block with a myocardial infarction. And so useful to get different treatment. I see people also did say potential posterior MI, and that if when looking at this, we know that these are, you would have an R wave as an equivalent for a Q. So if you were to flip the ECG around, then that would be suggestive of a posterior MI. But with the presence of the pacemaker, we know that there is a left bundle branch block. And then the key to that is determining whether there's a myocardial infarction in the presence of this bundle branch block. Alrighty. So this is also, there are some really tough ECG here. And this would be a left bundle branch block as well. So we can see that this is atrial fibrillation with the left bundle branch block with no discernible P waves, not preceding any QRS complex. So it's irregularly irregular. And then the very wide and bizarre QRS waves. But these QRS waves, these are discordant, but not excessively discordant. And there's no concordant ST segment depression. And so this is just a left bundle branch block without MI. So it's a lot to take in and a lot to remember, but just for yourselves and in your own time, just go to the modified Scarbosa's criteria. And that helps us to determine pathology in the presence of a left bundle branch block. All right. Here we see that this is a narrow complex supraventricular tachycardia. There are P waves preceding every QRS complex. So we say that this is a normal sinus rhythm. And the aberration is that there is a widened QRS complex with a tall right-sided bunny ear. So it's an RSR prime, suggestive of a right bundle branch block. And a key learning point from this ECG I spoke to earlier was that a right bundle branch block on its own should never produce axis deviation. And so here I have my right hand is pointing down in AVF while my left hand is pointing up in lead 1. And so I have a left axis deviation in the presence of a right bundle branch block. And so whenever I look at an ECG and I see a bundle branch block and I see axis deviation, I know that this patient is in serious trouble as it's a bifascicular block, meaning that there is a right-sided bundle branch block and one of the branches of the left bundle, whether anterior hemiblock or posterior hemiblock, are also blocked. And so this patient would definitely go in, it's a high-grade block, and the patient could go into AV dissociation and heart failure. And so this is a bifascicular block, as we did have 7 correct responses here. And the key take-home points, again, is just right bundle branch block never produces an axis deviation. And if it does, it's a bifascicular block that needs referral to cardiology for a pacemaker. Alrighty. So this is a sinus tachycardia, also quite difficult to discern, but we can see P waves preceding each QRS complex, regular, narrow. All of our intervals seem to be quite regular, and diffusely throughout our ECG, there's ST segment depression. So we know that when we do stress ECGs on patients, we expect, and there's different values for what we expect in terms of our ST segment depression within that ECG, and it's just the sign of hypoxia, and during diastole that the coronary arteries are not filling to reperfuse the heart. And so generally this is classically what you find in a sepsis patient, as they have a tachycardia and a not perfusion, and the widespread hypoperfusion would cause ST segment depression. But stimulants as well, as they would induce a tachycardia, is also a correct answer. The principle just being that the tachycardia is beating too fast to allow adequate perfusion of the heart, and it's causing a diffuse ischemic pattern. Alrighty, I think this is our last one. And so here we can see that it does seem like a regular rhythm, but it's broad complex. And so 5 responses, yes, that is typically, if we can be honest with ourselves, what we see in casualty and how we feel when we look at these ECGs. And a lot of people said that this was a ventricular tachycardia, and they would argue for that on the basis of no discernible P waves preceding and a broad bizarre pattern. And then this ties into our next question of, if I have a left bundle branch block or a right bundle branch block and a supraventricular tachycardia, I'm also going to get a regular broad-based pattern. And the question is, how do I differentiate a ventricular tachycardia from a supraventricular tachycardia with aberrancy? So a supraventricular, if it's a sinus tachycardia or AV nodal tachycardia, just with a delayed conduction. And so I would have to differentiate between them to determine if this is a ventricular tachycardia algorithm of management or SVT algorithm with management. And so in your own time, please do look at Brugada's algorithm, and there's just steps. And so no one would be faulted for thinking that this is a ventricular tachycardia, but it's actually an SVT with aberrancy. And a useful thing that we can do is the Lewis leads, where we move our right-sided limb leads onto the sternum. I'll share that picture is in the slide. And then it just gives us a really good look at what the atria is doing. And on this case, very difficult to differentiate, but when doing the Lewis leads, you can see the atrium depolarizing quite nicely prior to each QRS complex. And so that was the next question, just Brugada's algorithm. It has a stepwise approach in terms of discerning wide complex tachycardia, if it's VT or SVT with aberrancy. So yes, that's all from my side. Sorry, I know that's a lot of info, and I try to make it within the hour. I see there are a few questions within the chat. So
yeah, there's also a question on the Q&A. I think there's a sort of general question on the Q&A and then some sort of questions. You can take the one on the Q&A. I'll just respond to some of the questions.
Sure. So the question on the Q&A is, on a practical level, what should we be doing at CHCs if there is no ECG machine or leads or paper? Should we refer every patient with chest pain for an ECG, since it is the standard of care? And so it is the standard of care that a patient should get an ECG, and you would be at fault to send a chest pain that is a suspect home without doing an ECG. And in the rare event that the ECG is not actually working at your clinic, then you have high enough suspicion to send that patient. However, I'm sure we've all worked on both sides of the receiving and referring field, and to get patients sent for just an ECG is really, it's poor quality and poor practice from us as professionals. And so as clinicians within the primary care sector, we're not only looking at ECGs or taking bloods or putting our stethoscope, we also advocate for our patients, and we start at the start of our shift or of our call, and the ECG should be there. And when a nurse or someone says to you, the ECG is not working, if you go and look at it yourself, you're definitely able to, 99% of the time it is functional. It was just the paper was inserted incorrectly, or we didn't know where to access the leads. And so perhaps in the beginning, you would have to refer for ECGs, but over time we are advocates and we are responsible for clinical governance. So we should advocate to get ECGs and leads within our clinics. All right, I don't know if there are any other questions. I don't know, Prof. Musa, if you want to add to that. Or if there are any other questions.
I don't see any other questions, but if you don't mind quickly filling in the poll so that we get a sense of who's around the table, I think it'll just help us to see if people are participating from other than Durban. I see some people from Shwane. So it's really helpful. So if you can just quickly add in your details. If you have any other questions, use the chat or the Q&A, or you can just lift your hand and I'll allow you to ask the question or comment. I know we've run over the hour. We don't have too much time, but if you want to, I think lots of people. So if you can just also share in the chat your thoughts about the lecture, whether it was useful or not, I'm sure Shane would appreciate some feedback. Great.
And
So I can just stop it here. It's about halfway that we have people. So it's mostly interns from Joburg. Thank you.
And for the audience, useful ECGs, we sort of have to iteratively get used to ECGs and familiarize ourselves. And that's how we sort of build confidence and comfort with interpreting them. And useful resources, many would be familiar with Life in the Fast Lane, but there is a sort of a weekly ECG weekly by Prof. Amal Matu. And it's less than 250 Rand for an entire year with a weekly sort of teaching on ECGs that really does reshape how we know and interpret ECGs.
Great. No, thank you very much. Would you mind just sharing with me by email those resources and Shane's lecture, as well as his the resources is pointing to, some links and other useful resources will be also on the website with the recording. Does that sound fine, Shane? You can provide me that.
Yeah,
great.
I'll do.
Wonderful stuff. Thank you all very much. I think there seem to be no more questions. Hope you found that useful. Thank you. I'm sure it did. Thank you very much, Shane. I really appreciate that you took time out to do that. I think lots of people found it very helpful.
Perfect. Thanks. Cheers.
Thanks, Shane. And goodbye to everyone. Bye-bye.